Hello. So I have the honor of introducing Dr. Sayari Patel, MD. She is an assistant professor of clinical medicine at the University of Miami Miller School of Medicine. She started her medical career at the University of Miami Miller School of Medicine in the MD MPH program. She went on to complete her internal medicine residency training at Boston Medical Center and has now returned home, recently joining the Department of Hospital Medicine as an academic hospitalist. Her research interests include global health, medical education, and quality improvement. She will be presenting updates in hospital medicine 2024.
Thank you for the introduction. I'm super excited to be here and share some updates in hospital medicine. Can you hear me? No. Yeah, thank you. So just first off, to start off with some disclosures, the first one being that I am not a specialist, so everything that I'm going to be presenting is through the lens of an internist. But I've tried to compile some studies that, cut across various specialties and encourage debate and comments from colleagues in various departments as well, because a lot of what I'm going to be talking about is fairly new and a lot of it is not yet incorporated into guidelines. And the second disclosure being that I have no financial disclosures. As far as how I put this presentation together, so I identified literature roughly starting from September of 2023 up until now, and wanted to talk about some pieces that did one of a couple of things. One, either they're going to change the way that we practice. Two, they either confirm the way that we practice and reassure us that the way that we've been doing things all along is the right way to do things, or they kind of present something that is new and upcoming in literature. It is not going to include anything that's COVID related, so everything COVID is excluded. And one of the main things in relation to this presentation is that it's going to be a focus on breadth rather than depth of contact. There are a couple of takeaways and teaching points that I hope that you guys will get through this presentation. So at the end of this talk, I hope you guys familiarize yourself a little bit better with the first question was, should we treat pneumonia with steroids? The second question being, what is the optimal fluid choice in patients with pancreatitis? The third question being whether beta blockers are necessary in all patients post-MI. And the last question being, is 7 days of treatment for bacteremia non-inferior to 14 days? So just to start off with a little bit of a case. So you're in the hospital, you have the 78-year-old gentleman, they have a history of CAD, CKD, CVA, they have prostate cancer, heart failure with preserved ejection fraction. They're coming into you with a cough and a shortness of breath. You're seeing them and they're already in step down on 10 liters of high flow at 60% FiO2, and they're satting around 95% on this oxygen level. They're tachycardic, hundreds to 110s, respiratory rates around 31. Their febrile temperature is 100.4, and their blood pressure is pretty stable at 120/80. On exam, they're not looking so great. They have bilateral crackles, and they're still tachycardic when you go to see them. Workup has been done for them so far. They have a leukocytosis up to around 18K. Their Mercenaires was negative, their respiratory panel was negative, and they don't have flu. Point of care ultrasound was actually done on this patient. There wasn't much a concern that they're fluid overloaded. Their chest x-ray had bilateral pleural effusions and then also multilobar consolidations. A gas was done. A pH was 7.4, PO2 was 80, PCO2 was 40, and they're currently on ceftriaxone and azithromycin. So my first question to everybody in this room by show of hands, would you add steroids in the management of this patient? So show of hands for yes. Nobody. Okay. Show of hands for no. Everybody. Okay, nice. And since nobody actually said yes to doing steroids, I guess this question's not super pertinent as far as what would be your steroid of choice. But to those of us participating at home, would you have chosen Dex? Would you have chosen methylpred? Would you have chosen hydrocortisone? Or would you have chosen prednisone? So the first question that I wanted to kind of touch base about and provide some updates in the literature is regarding whether steroids should be used in the management of CAP. And this question is not new at all. Before it was like, yes, we should do this, and it was no, we shouldn't do this, and kind of the data has been all over the place. And a lot of the critiques of this has been that a lot of the prior trials were not powered high enough. There's so many different types of steroids that have been used and not a lot of guidance on what we should be using. And the inclusion and exclusion criteria in a lot of these trials have been super variable. So I wanted to talk a little bit more about this specific study that was a meta-analysis that helps to address some of those questions. So as far as the study, it was a systematic review, and they've reviewed randomized controlled trials. And a total of 18 studies were selected, 10 of which were defined as severe pneumonia. So at least greater than 50% of the participants in the study had to have meet criteria for severe pneumonia. 8 were non-severe, and it was a total of around 4.6K patients that were analyzed in this meta-analysis. And it was a mix of different steroids, different duration protocols, et cetera, for what they were studying. And they were hoping to kind of get a better answer as to what might be more or less beneficial. And the other important thing is that this is one of the first systematic reviews and meta-analyses that came out after the 2 large trials, Cape Cod and Escape trial, which are frequently referenced now when discussing the topic of steroids and pneumonia. So the Cape Cod trial was a trial that there were nearly 800 patients or so. It was a randomized controlled trial, only including patients with severe pneumonia, and their protocol used IV hydrocortisone. And then the Escape trial was done at the VA, and it was a placebo-controlled randomized controlled trial of around 600 patients or so. And the Cape Cod trial showed that there was some mortality benefit. The Escape trial showed there wasn't really much of a mortality benefit. So this did include those 2 large studies. My first question, though, when I was reading this was, what in the world is severe pneumonia and how are we defining it? And this could be a talk in and of itself, but there's a lot of variability in how it's defined. So the ATS and the IDSA basically just defines it by having at least 1 major criteria or greater than 3 minor criteria. And the major criteria being, is this patient, do they have shock? Are they on pressors? Are they ventilated? Those would all qualify as major criteria. And there's a whole bunch of different things that are listed for minor criteria, but if they meet more than 3 of these per the ATS and IDSA guidelines, they would be considered as having severe pneumonia. Now, this is very different to the Cape Cod trial and what their inclusion criteria included for patients to consider them as severe pneumonia. And one thing to know is that the Cape Cod trial only included patients that were in the ICU or stepped down because of their pneumonia. And the way that it was defined was, are they ventilated? Are they on high flow and have a P/F ratio that's less than 300? Or do they have a pneumonia severity index that's greater than 130? So the PSI does include some of the things that are included in the ATS guidelines. But again, the definition of severe is quite variable between these 2 things. And then you have another definition of severe pneumonia, which includes various risk stratification scores. So this study actually included all of these different definitions because of the various studies that were included, but just wanted to highlight that severity is kind of all across the place. For me, when I'm thinking about it clinically, all of these things weren't super helpful for me. I was more thinking about it, am I looking at a patient that I think is about to end up in the ICU because of their pneumonia? And that's what I'm looking at and thinking this is a pretty severe pneumonia. But I didn't find looking at a lot of the risk stratification scores and other things to be super helpful. So this study in particular, the main outcome was looking at mortality, and it was comparing severe CAP and non-severe CAP. As far as what they found, the relative risk was 0.62, and it was pretty significant from the confidence interval. When you're looking at the absolute risk difference that they were talking about, it was roughly around 56 fewer deaths or so per 1,000 patients, and this was in severe CAP. This difference was not found to be true when you're looking at non-severe CAP. So the benefits were only seen in severe CAP. There were some other secondary points of outcomes that they were looking at. So looking at whether there was decreased mechanical ventilation, decreases in ICU admission, any sort of possible shortened length of stay. And there were some benefits that were seen in those as well, but the primary outcome was looking at mortality changes. And then they also looked at whether there were any sort of adverse effects associated with steroid use. So that included whether there was concerns for GI bleed, any sort of other infections. And as far as the other adverse effects, the GI bleed and infections wasn't really seen, but there was more hyperglycemia, but not a lot of other adverse events that were seen in this population. So that answers the question of severe versus non-severe per the study about, whether I should consider using steroids. But then there's a question of which steroid should I be using and what is actually optimal or not. So this study did also stratify that and look at whether particular steroids were more beneficial than others. So Dex and prednisolone were not super common steroids used in the different protocols analyzed, and there wasn't really much of a benefit that was seen. Hydrocortisone was the steroid of choice in the Cape Cod trial, and methylprednisolone was the steroid of choice in the Escape trial. And so most of the weight that was put for hydrocort and methylpred in this study did come from those 2 studies. And it seems like there is some flavor of a benefit associated with hydrocortisone. So the reason why that's the case is pretty unclear. So it's not clear whether, it might be confounding by treating potential shock that could be occurring in patients, and that's why it's more beneficial. But there appears to be a relative relative benefit to hydrocortisone over some of the other steroids when you're thinking about using steroids for pneumonia. There are a lot of areas for further study, and the study is, it's not done as far as answering this question because there still needs to be more studies done as far as what steroids you should be using, because a lot of the weight did come from those two particular trials. So this is still a point of interest. It's not clear, whether hydrocortisone really does have that much more of a benefit in comparison to the other steroids or not. Then the other one is the role of steroids in less severe CAP. So for this particular study, when they were looking at the meta-analysis, the benefits were only seen in severe CAP. However, there's newer studies looking at less cases of severe CAP and whether there's any sort of benefit associated in that as well. And then looking at microbiologic subgroups. So we know that steroids are not beneficial in pneumonia that's secondary to influenza, but the study doesn't elucidate anything as far as whether there are certain types of bugs where steroids might be more beneficial than others, similar to studies in meningitis. And as far as what the guidelines say, so the ATS and IDSA guidelines from 2019 currently do not recommend routine use of steroids. Their usage of steroids is recommended in patients with concurrent septic shock. However, there's no criteria for saying that we should be using steroids in severe pneumonia. But the interesting thing is kind of based off of this meta-analysis and then also additional studies that have come out, the Society of Critical Care Medicine did issue this guideline that does favor a recommendation for using steroids just for severe CAP with a moderate certainty of evidence. And then as far as their protocol, they don't fully comment on a specific protocol that might be more beneficial than others, but they do suggest the use of hydrocortisone that's less than 400 milligrams for roughly around 5 to 7 days or so. So the takeaway for me is, in those patients that I have that are extremely sick, like about to end up in the ICU, these studies did make me consider using hydrocortisone in severe pneumonia. And the patients that I'm considering severe to be those patients that I think are peri-ICU or already in the ICU, because there might be some benefit that's associated with it. But I think that it's another one of those areas where there's further studies that are needed to kind of incorporate this fully into our guidelines. All right. So your patient is now back at the hospital, but it's been after 30 days, so you did a great job with them the last visit. They're coming in with abdominal pain. They have some nausea and vomiting. Their belly's tender. On exam, you did a lipase on them. It's 900. You're thinking that this patient has pancreatitis. So another poll. So what fluid would you use in acute pancreatitis? You're thinking about this a little bit more because you have this notification coming up that we're in an IV fluid shortage and you're just being super mindful. So who in this room would select LR? Okay, it's like 75% or so. Who in this room would select normal saline? Very, very timid, very timid show of hands for normal saline. And who thinks there actually isn't a difference? It doesn't matter if I use LR or normal saline. We just need to give them fluids. Everything will be fine. Okay, so 20% of the room thinks that there's no difference. Okay. So I wanted to talk a little bit more and touch base on the question of whether there is an optimal fluid choice in patients with pancreatitis. So I wanted to bring to your attention this meta-analysis. I kind of wanted to address that question of comparing LR versus normal saline and seeing, whether there was any sort of benefit of one versus the other in acute pancreatitis. So this study in particular, it was another meta-analysis. It included randomized controlled trials as well as observational studies. And then as far as the breakdown itself, there are roughly around 5 RCTs and 4 observational studies that were included in this for around 1,400 patients or so that they were looking at and analyzing. And as far as the etiologies for pancreatitis, it was variable. There were patients with alcohol-induced pancreatitis included, gallstone pancreatitis included, which are some of the most common etiologies. And the randomized control trials themselves were actually fairly small. So there are a lot of patients enrolled 60s or 70s or so. And then as far as the outcomes that they were looking at, so one was development of moderate to severe pancreatitis. So that basically means did this disease itself get worse? Did they have SIRS, organ failure, acute lung injury, other things that were associated with their pancreatitis? The second thing was looking at ICU admissions. And the third was looking at local complications. So that includes things like necrosis or abscesses that are developed. So for this, the odds ratio was around 0.5 or so. So the rate was roughly cut in half. When you were looking at like the absolute risk that this was pointing towards in the study, it was roughly from like 20% to 10% as far as the difference. And then similarly for ICU admissions and local complications, there were statistically significant benefits associated with using LR over normal saline. There were some benefits as far as length of stay. So there was around 1 day of decrease in length of stay, but there's no sort of notable changes or benefits as far as differences in mortality or some of the other outcomes that they were looking at. The limitations and further areas of study for this, one, it didn't include plasma light, which is another fluid of choice that is often used as well. And the actual authors of this commented on the fact that there needed to be larger randomized control trials before, providing more conclusive evidence that LR is more beneficial than NS. But there actually is some pathophysiologic proof or kind of theories behind why LR might be more beneficial than NS. So one being inflammatory related. So the thought that lactate actually suppresses NF-kappa B, which is hypothesized to contribute to some of the inflammation in pancreatitis. The other being that LR provides some calcium that can bind to some fatty acids that are associated with more severe disease in pancreatitis. And the third being that NS could potentially create a more acidic environment, which would make it more susceptible to pancreatic injury. So there are some pathophysiologic things that kind of point towards why there might be a benefit that we're seeing in the study for LR in comparison to NS. And in the March 2024 ACG guidelines, they did actually comment on the question of LR versus NS, suggesting LR over NS, but it is a conditional recommendation with, they noted, low quality of evidence, which is similar to what the authors were noting. But for me, I think the takeaway is that there isn't much of a harm to this of using the LR versus NS. There is a potential benefit that is associated with using LR over NS, and there's little to no difference as far as like cost or utilization or other things that you would look at when using LR versus NS. So my takeaway was like when I'm treating my patients with pancreatitis, I probably will be reaching for LR over NS, and that there probably is some sort of associated benefit with doing so. And the second bullet point is just pointing towards some of the evidence from the waterfall trial, which I'm not going to go into, which suggests a moderately aggressive strategy for fluid resuscitation in comparison to kind of like aggressive fluid resuscitation. So for this same patient, you're also just, talking to them and doing their intake and completing their med rec. And then you see that they're on metoprolol. You ask the patient, about their medications. This patient tells you that they have no clue why they're on this medication. It makes them feel funny when they take it. They're not entirely sure. You randomly recall hearing some sort of studies about beta blockers and MIs, and you know that this patient has had a history of MI and they also have a preserved EF, and you wonder to yourself, are beta blockers necessary post-MI in all patients? So to poll the room, who says yes? Oh, interesting. Okay. So there's just one vote for yes in beta blockers being necessary post-MI. Who says no? Okay. So the majority of the room says no, that beta blockers are not necessary post-MI. Okay, so I wanted to include something that was kind of at the intersection of hospital medicine and also the work that's done in primary care, because beta blockers are one of those medications like aspirin and PPI that are kind of like a mystery to patients and to me sometimes as to why they're prescribed them or why they're on them in the first place. But oftentimes, one of the times that I'm looking at it and I see that they have a history of MI or they have a history of reduced EF and all those other things, my thought is to say, yes, there is an indication for them to be on a beta blocker. But I wanted to point towards this study, the Reduce AMI study, which recently came out in the New England Journal of Medicine, to kind of help understand this question a little bit better as far as, which patients might benefit more from beta blockers post-MI, and is it actually necessary in all patients post-MI? So what the study was itself, it was a randomized control trial that was registry-based, and it was a non-inferiority trial. It was non-placebo, which I'll go into a little bit more when I get into the methods of it further. And most of it was based on the Sweetheart registry. So a lot of the patients that were enrolled in it were from Sweden, but it was European and multi-center. So there were some other countries and other locations involved, but primarily based off of the Sweetheart registry. And their primary outcome was looking at all-cause mortality and recurrent MIs in patients. And there are a couple of different secondary outcomes that they were looking at as well. And as far as how the study was broken down, so it selected around 5,020 patients who were all acute MI status post-revascularization. And they were broken down into two groups. The first one was the beta blocker group. So they received either metoprolol 100 or bisoprolol 5 with a preference for the metoprolol, or they were not on any sort of beta blocker. And the no beta blocker group, if they were already on a beta blocker prior to being selected into that group, then there was a protocol to kind of wean them off of the beta blockers that they were on. And as far as some of the other inclusion criteria, so this only included patients who had an EF that was greater than 50%. So anything less than that was not included. And it included patients that had some flavor of angiographic evidence of an obstructive process. And for the exclusion criteria, if a patient already had another indication for a beta blocker, they were not included in this study. And what this study found, they looked at a lot of different endpoints, but one was looking at mortality, one was looking at acute MI rates, the other was looking at the rates of hospitalization for heart failure. And the percent difference was 7.9% versus 8.3% in the beta blockade versus the non-beta blockade group. For MI, it was around 4.5 versus 4.7%. And then for heart failure hospitalizations, it was around 0.9 versus 0.8 versus 0.9%, and the confidence interval for all of them crossing 1. So there wasn't much of a statistically significant difference that was seen between these groups in terms of utilization of a beta blocker or no beta blockade in patients who have heart failure with preserved EF and also an acute MI. As far as what our guidelines say, so per the AHA and ACC, for patients who do have normal LV function, it's a class 2A recommendation. So it's still part of the guidelines as far as using beta blockers for these patients. But part of what the study points towards is that a lot of the evidence for the benefits of beta blockade was based on studies that were done much longer ago when there wasn't as much GDMT around, there wasn't as much early revascularization around. So it highlights this need for further studies and really that can really elucidate which benefits, which patients would benefit from beta blockade. Limitations and further study for this in particular, it did not include a lot of patients that you would probably see in the hospital that are intermediate and high risk. So a lot of the patients that were seen, there were a small proportion of patients who had a history of prior MI or prior stroke or prior heart failure, which is what you're going to be probably more used to seeing in a lot of your patients. So it was a fairly healthy-ish population that they were seeing in this study. And the other thing is that it was largely an STEMI study, so only 35% of the patients that were enrolled in the study had ST elevation MI. And the follow-up time was only around 3.5 years or so for this study, but anticipate that they probably will have further data coming out sooner or later. And then adherence was another issue. So in the arm of patients that had no beta blockade, roughly around 11 to 13 months afterwards, around 15% of that population were on beta blockers. So there were some adherence issues in terms of the study itself. But for me, I think the takeaway is that I think before it was kind of like holy grail as far as usage of beta blockers in patients, especially patients post-MI, but this study kind of highlights that we should be taking a closer look at which patients in particular do benefit from beta blockers post-MI, and that in my low-risk patients who do have preserved EF, that it may not be needed, and it probably will be something that I would have a discussion with their outpatient provider as well as cardiology about whether a beta blocker is indicated in those patients, especially those that have a high burden of pill burden or any sort of like possible side effects. And there's some other studies down the line that are coming out to help address this question a little bit better. So now for your patient, day 4 of their admission rolls around. They're having some fevers, chills. There were cultures that were collected showing E. coli. So pulling the room, what would the treatment duration be? How many folks would say 5 days of treatment? Okay, 1. 7 days of treatment? It's around like 40% or so. 14 days of treatment. Okay, so that's like 5 or 6 people. Okay. So the last trial that I'm going to be talking about is the BALANCE trial to help address this question a little bit better as far as whether 7 days of treatment is for bloodstream infections is non-inferior to 14 days of treatment. And this is the BALANCE trial, which came out like pretty recently in November. So what is actually different about this trial in comparison to others and why it's important is that it includes a much larger sample size in comparison to some of the other studies that were done in the past. So some of the other studies in the past included around like 200 to 600 patients or so, and this was much larger. And their non-inferiority margin was actually much smaller as well. So in prior studies, it was roughly around like 10% or so, and theirs was 4%. And it includes extremely sick population as well, which was not as well represented in a lot of the prior trials. So it does include a large number of patients that are in the ICU. And the last piece is that this study includes a broad range of pathogens. So it's not just looking at gram-negative bacteria, and it's not just looking at gram-positive bacteria, but kind of spanning across the spectrum. It was a randomized control trial. It was, again, another non-inferiority study. And it was using data from 74 different hospitals across 7 countries. There were various exclusion criteria for this that were kind of specific to the host or the patient itself. So it did not include neutropenic patients. It didn't include immunosuppressive patients who are on immunosuppressive treatment. It did include patients that were on steroids, but this was more if they had like transplants and were on immunosuppressive treatment, or patients that heart valves. And then there was, as highlighted here, there were some exclusion criteria that were specific to kind of the source of the bacteremia itself and specific syndromes that require longer courses of treatment. And then also did not include staph or specific fungemia and some other rare organisms. This trial, there wasn't like a protocol that was prescribed by the folks doing it to the providers as far as like whether a patient needed to be on IV medications or needed to be on PO, what the dosage was, the frequency or the antibiotic selection, and it was kind of up to the providers themselves. And then as far as the findings, so there are around 3,608 patients in this trial. Around 1,800 were in the 7-day arm, around 1,700 or so were in the 14-day arm. And then 55% of the patients came from the ICU, 45% from the wards. And then as you can see, the source of the pathogens was super variable. And then this slide kind of talks about some of the pathogens involved. So it included like strep pneumo, Klebsiella, Pseudomonas, but mostly primarily gram-negative species. And a couple of different outcomes that they were looking at. So they were looking at mortality, length of stay, like rates of C. diff, rates of relapse of bacteremia, and the 17 versus 14-day arm. And so as you can see here for mortality in the 7-day arm, it was 14.5 versus the 14-day, which was 16.1. And it did meet their criteria for non-inferiority. And it was similar as far as length of stay, C. diff, and relapse, where there weren't super notable or significant differences that were seen between the two groups. So this study essentially was showing that the 7-day arm was non-inferior even across ICU and wards, and also non-inferior across various sources and pathogens for bacteremia. There are some limitations and areas of further study for this as well, in that it's not applicable to patients that have staph. There are some studies that are currently ongoing that do look at the question of staph, but this is not one that is able to comment on them. And then similar to the prior studies, there was also a high rate of non-adherence, though their analysis was pretty similar for both the intention to treat and the per protocol analysis, as far as no notable differences being seen between the 7 and 14-day studies. And this comments only on duration of bacteremia treatment, but doesn't add to the literature as far as early step-down therapies and transitioning patients from IV to PO. So the takeaway being that 7 days of treatment for bacteremia is non-inferior to 14 days, and it adds to the growing body of literature that supports that case. So if you just remember these things, 1, should consider hydrocortisone use in your patients with severe CAP. 2, use of LR over NS for pancreatitis management. 3, in your low-risk patients who have preserved EF, beta blockers may not be needed post-MI. And 4, that 7 days of antibiotic treatment are non-inferior to 14 days for most bacteremia.
Thank you, Dr. Thank you, Dr. Patel. Any questions, please put them in the chat and we'll be sure to get them to Dr. Patel. That was a very instructive, informative lecture. I just don't know why the CMS still has in MIPS the use of beta blockers is actually, we're dinged if we don't write that in. So important information. Okay, let's introduce our next speaker. Thank you, Dr. Weiss.
Thank you for that talk, Dr. Patel. Introducing our next speaker is my honor as well, Dr. Pedro Covas, one of our own. He's a South Florida native. He completed his undergraduate studies at the University of Miami. He earned his medical degree at Temple University's Lewis Katz School of Medicine and completed his internal medicine residency and general cardiology fellowship at George Washington University, where he served as a chief fellow in his final year. Dr. Covas then completed a cardiac imaging fellowship at Baylor Scott and White, the heart hospital in Plano, Texas, specializing in interventional echocardiography and cardiac CT. Now back in South Florida, Dr. Covas is an assistant professor at the Miller School of Medicine at the University of Miami and serves as director of structural imaging.
Thank you for the introduction. Just see, where do I go to next? Thank you very much for letting me give. Oh, how do I do that? This one? This one? Or display settings? Swap. There we go. Perfect. Good. All right. Well, thank you again for the introduction. Thank you for letting me give this talk. So I'm going to give a little updates in cardiovascular imaging. And those disclosures to present. And the objectives of this talk, well, is to provide a broad overview of updates and relevant topics in the cardiovascular field, particularly with an emphasis on cardiac imaging. Some of the topics we'll be talking about are transcatheter tricuspid interventions, mitral annular disjunction, intracardiac echocardiography for structural procedures, and ischemia for cardiac CTAs. So moving on to transcatheter tricuspid interventions. As you can see here, tricuspid regurgitation is very prevalent. It's expected to moderate or more tricuspid regurgitation is expected in about 1.6 million Americans. On the left is an image showing how complex the mitral valve or the tricuspid valve is. Sometimes you can have 3 leaflets, you can have bicuspids, you can have up to 7 leaflets, and there's significant morbidity, mortality with moderate or more TR. And you can see on the bottom, there's multiple etiologies, primary, secondary. And most recently in 2024, we had 2 pivotal trials that came out for tricuspid interventions. On the left, you can see is the TriClip trial, which is transcatheter edge-to-edge repair, or T-tier, tricuspid tier. And then on the right, you can see the EVOQUE valve, which is transcatheter tricuspid valve replacement. And both were randomized controlled trials that were published in New England Journal of Medicine. There was about 400 patients in each trial. They were enrolled in either medical therapy, which is just diuretics essentially, and afterwards, or the intervention arm, which is either the TriClip or the EVOQUE valve. The primary endpoint for both of them were pretty much composites of death from any cause, hospitalizations, and quality of life. And at 1 year, both of the interventions actually showed that there was a primary outcome favoring that, mostly guided by quality of life metrics. That ultimately left to the FDA approval in early 2024 for the Edwards EVOQUE system, and subsequently afterwards we had the TriClip also FDA approved. Now we're waiting for CMS approval for reimbursement, which could probably anticipate in the next year. So when thinking about while we're waiting for that, does everyone with tricuspid regurgitation qualify for a tricuspid transcatheter intervention? Well, first of all, it's a multidisciplinary and heart team approach to each patient. You know, we're going to be discussing with our surgeons or interventionalists and to see which option would be the best. But what are, to review, what are the current guidelines for tricuspid intervention? So there's actually only one level 1 evidence for tricuspid interventions, and that's a patient with severe tricuspid regurgitation undergoing a left-sided surgery, so either a SAVR, mitral valve repair. That would be the only reason to intervene for level 1. Looking ahead for isolated tricuspid valve surgery, the 2020 valvular heart guidelines only showed that there's a 2A's and 2B recommendations to reduce heart failure symptoms and right-sided heart failure in a lot of these patients. But otherwise, other than the 2A and 2B and some RV dilatation, there's no there's only a low level of evidence to have an isolated tricuspid valve surgery. So where will EVOQUE and tricuspid T-tier fall in the guidelines? I don't think anyone really knows yet. But if we were to extrapolate to the mitral guidelines, if you look right now in the valvular heart guidelines for mitral regurgitation, transcatheter edge-to-edge repair is a 2A indication for patients who are high risk primary mitral regurgitation or persistent symptoms on GDMT in the secondary mitral regurgitation. So I think we can probably expect that we'll probably have a similar indication in the future once CMS is fully approved of this. But while we're waiting for that, we have two options. We have a clip and we have a replacement. And who is a better candidate for each one? And there's a lot of things that go into that. So the right ventricular function is one thing. So patients with severely reduced RV dysfunction may not be able to tolerate having a transcatheter valve replacement, and it might be favorable to have a clip at that point. Ability to tolerate anticoagulation is one big thing. A lot of these tricuspid regurgitation patients have liver disease, congestive hepatopathy as well. So a lot of them INRs are elevated, inability to tolerate anticoagulation. With the tricuspid valve replacement, you would have to be anticoagulated. So that's one of the indications that you might want to start leaning towards a clip. In anatomical suitability. So when looking for a transcatheter edge-to-edge repair from a tricuspid side, in 2024, the GLIDE score recently came out, and this kind of helps the echocardiographers decide on how successful a tricuspid clip would be. And it comes with 5 components that spell out GLIDE. And G stands for gap, and it kind of makes sense. If you have a very wide gap, it's going to be hard for 2 clips to be able to be grasped. The location for L, an interoceptal location is very favorable. There's less shadowing from the device. Other locations have become very difficult. The imaging quality, a lot of the echocardiographers probably know that some patients are just better imagers. Some patients have hiatal hernias, which make it difficult for during a TE to guide procedures. You have a lot of prosthetic valve shadowing. Some patients are just better than others. D stands for the chordal density. So patients with a significant amount of cords end up having a risk of entanglement with the procedure, and that might be easier to replace than repair. And then E is the en face morphology. So patients who end up having more localized lesions, linear lesions, rather than the whole valve just lights up. And what we're looking for is a reduction in tricuspid regurgitation of greater than 2 grades, they're greater than or equal to, and at least moderate TR. And those were observed in about 90% of patients with lower GLIDE scores, 0 and 1, compared to those who had higher GLIDE scores. So when we're talking about TR reduction, most of us lived in a time where there was only 3 grades of tricuspid regurgitation. We had mild, moderate, severe, maybe some shades of mild to moderate, and some shades of moderate to severe. But what a time to be alive. Now we have massive tricuspid regurgitation. We also have torrential. And what we're trying to look for is actually a 2-grade reduction to get to moderate. So you can go to torrential to severe, but we're still looking for at least moderate or less in the trial. So ideally, you would try to go from massive to moderate or severe to mild. So ultimately, we have a new treatment option for our high-risk patients with symptomatic tricuspid regurgitation. It's a technically challenging procedure with significant imaging guidance, and it's likely going to be left at expert centers. And I expect us to be one of those centers once it's fully reimbursed by CMS, and we have some guidelines from there. Moving on to another topic of mine, that I particularly enjoy is mitral annular disjunction, or MAD. So for those of you who are not familiar with the condition, it's an anatomic separation of the mitral annulus from the typical location between the left atrium and the left ventricle. So in the red arrow, you can see here at the junction of the left atrium, the left ventricle, this is where the posterior mitral annulus should attach. And in this patient, you can see in the yellow, it actually attaches into the left atrium. And this is frequently seen in patients with mitral valve prolapse, and there's an association with arrhythmogenic mitral valve prolapse and sudden cardiac death. And how can multimodality imaging help us in this particular pathology? Well, as you can see in this histopathology slides, we really need to identify the presence of mitral annular disjunction. And as you can see in the top left, the mitral valve in this one with no MAD sits right in the junction of the LALV, no mitral annular disjunction. But in the right histopathology, you can see that the mitral valve actually sits in the left atrium and attaches there. And there's a significant amount of fibrosis all around the left ventricle in that area between below the annulus and the LV. And imaging will help us determine, is there truly posterior leaflet insertion in the correct spot? Could you have pseudo MAD? So you have a little bit of curling of the leaflet and it kind of gives the appearance and mimics MAD, or do you truly have insertion on the bottom right, as you can see, in the left atrial wall? And this also helps us, imaging will also help us determine the risk of sudden cardiac death in these patients. So when looking over here, anyone who's survived sudden cardiac death obviously gets an ICD, but those who are asymptomatic or have palpitations, it becomes a little bit, or syncope, it becomes a little bit more difficult who should get an ICD, who shouldn't. So a lot of those patients end up getting Holter monitors, exercise testing, and if you have VT, then you should consider some kind of medical therapy, surgical repair, or ICD placement. For the patients who are asymptomatic, there are some high-risk imaging features that can help us. So patients with severe mitral regurgitation, greater MAD length, if there's fibrosis noted in the left ventricle, if there's increased mechanical dysynchrony from the left ventricle, if you have a reduced EF, that makes you a higher risk. Global longitudinal strain, if you have bileaflet prolapse compared to single leaflet and redundant leaflets, and then a peak strain pattern on strain imaging is also considered a high-risk feature. That in conjunction with some VT, patients are very likely to end up with an ICD for primary prevention. And the use of multimodality imaging in mitral annular disjunction, well, there's a lot of images, different modalities we can use. Cardiac MRI is my favorite one to go to. So patients who end up having a cardiac MRI, you can actually look at the actual insertion. You can see here in the yellow arrow, very clear to see. You can actually quantify, it's the gold standard of quantifying mitral regurgitation. There's a lot of controversy on how much you include the prolapsed area of the mitral valve compared to where just the posterior annulus sits now. That's a lot of debate in the cardiac MRI world. It's the gold standard for ejection fraction quantification as well. Cardiac MRI in the second picture you can see actually helps us diagnose if there's left ventricular fibrosis. The papillary muscle is actually the most common place, puts a little bit of extra strain on there, and that's where it ends up getting fibrosis, and it becomes a nidus for arrhythmogenic and cardiac arrhythmias. In the cardiac CT has high spatial resolution. You can see here that you can actually quantify that the insertion is actually right there next to the circumflex. And FDG, so PET, can actually help us, and it correlates very nicely with fibrosis that's noted on cardiac MRI. So patients who for some reason can't get a cardiac MRI, maybe their renal function is poor, FDG PET is a suitable alternative. And on echocardiography, you can see that what we're looking for is something called a pickle hobby sign. So this is on echo diastology. A lot of echocardiographers despise diastology, but when there's concern for mitral annular disjunction, we need to look for increased mobility of the leaflet, and that's what's seen here with that 24 centimeters per second. And supposedly it looks like this pickle hobby German helmet. I don't know. I'm sure everyone here thinks that just cardiologists will make anything a sign nowadays, but this is so mitral annular disjunction is under-recognized, underdiagnosed, and undertreated phenotype of arrhythmogenic mitral valve prolapse. And most recently, the Carroll Act was passed into law in 2022. And this is from Andy Barr. He's a congressman there. His wife actually suffered from mitral valve prolapse. She had sudden cardiac death. No idea if she had mitral annular disjunction, but nonetheless, he proposed this, and afterwards he was able to get unanimous votes in Congress to get this passed. And this provided additional researching funds for particularly valvular heart disease in order to prevent this. So hopefully with increased research funding, we'll be able to look into more reasons to people with MAD, mitral valve prolapse. So with increased awareness and the use of multimodality imaging, early detection can lead to improved outcomes for our patients with mitral annular disjunction. Moving on to echocardiography. So another hot topic that's been coming up, particularly in structural procedures, is the use of intracardiac echocardiograms, or ICE. So it's increasing in the prevalence for interventional procedures. So as you can see here in the graphs from 2020 just to 2021, you've had a 2-3-fold increase in ICE. And that's particularly because it is essentially a mini TEE probe, maybe a little bit less imaging quality, that you're able to advance through the venous system, advance into the heart, and get echocardiograms right there. And, some of the pros and benefits of this is that we get moderate sedation. Patient doesn't have any risk of esophageal trauma. So a lot of patients we end up doing have some kind of strictures or esophageal cancer. So, avoiding a TEE would be very nice. It also improves efficiency in the cath lab. You don't have to worry about an imager. You don't have to worry about anesthesia. You just administer your sedation and go on. Some of the cons with it, you do have a slight decrease in imaging quality because of the amount of piezoelectrolyte crystals that can be fit in an ICE catheter. There's a learning curve. So before you had an imager who did the imaging and then the proceduralist who did the procedure. Now the proceduralist has to manipulate both catheters. Becomes a little bit of a learning curve. You have to learn the different views of the ICE catheter is a little bit different since the views aren't, you're in a different orientation than a TEE. It's a single-use catheter. Right now, they haven't found a way to make it reusable. So right now, it is costly to use one, but you have to look at it as it's more efficient in your cath lab, and you might be able to save costs in that way. And it's an additional vascular access, though it is venous. Less complications with venous than arterial, but still there nonetheless. And this is some of the images that you can see here. So on the left, you have an intracardiac echocardiogram for a tricuspid procedure. Pretty good. And then, this is a TEE image from a patient who has a mitral intervention. And you can see, if you needed 3D interventions, it's actually not too far off. And with recent updates from a lot of the companies, we'll soon be seeing much better color flow and 3D imaging from the ICE procedures. And I expect that we will be doing a lot more of these. And, with its increasing use, we'll also have improving technology. There's going to be randomized controlled trials in the future comparing ICE to TEE and the safety of these, particularly in left atrial appendage occlusions. I anticipate that maybe after left atrial appendage occlusions, we might be going to tricuspid procedures solely guided by ICE. And lastly, talk a little bit about cardiac CTA, so CCTA. As many people know, the chest pain guidelines came out in 2021, 2022. And I wanted to particularly guide you to this part of the slide because it's a very busy slide. So patients who end up having no prior testing and have an intermediate risk with no known coronary disease, your options are some kind of testing. So whether you have, and it's split into anatomical, which is the cardiac CTA, versus a stress testing, which is your traditional ECG, ETT testing, stress MR, PET, nuke, stress echo, anything like that. Both are level 1 evidence, but the only one that is actually level 1A with the highest level of evidence is cardiac CTA. There's multiple randomized controlled trials demonstrating the efficacy and the safety of cardiac CTA in the ED inpatient setting, as well as a high negative predictive value. And for those of you who have ordered a cardiac CTA or have had to read one, you've probably seen the CAD-RAD scoring system. The CAD-RAD scoring system, it goes from 0 to 5, and it's kind of quantifying how much stenosis there is. CAD-RAD's 2 system came out not so long ago and has similar to CAD-RAD's 1, and it helps you quantify how much plaque there is, put some extra modifiers. I haven't seen it really take into effect globally, but it seems like most people are still in the CAD-RADS 1. But I wanted to particularly guide your attention to patients who end up having possible obstructive disease. So if you have a CAD-RADS 3 or a CAD-RADS 4, where ACS is possible, ACS is likely, patients with above a 50% stenosis, there is this indication that we should be getting additional functional assessment. And luckily, if you already have a cardiac CTA, you can get functional assessment. And what you can do it is through cardiac CTA, CT-FFR. So this is actually a real case from not too long ago, a couple months ago, where we ended up getting a CTA. Noticed that there was quite, at least a moderate to severe lesion, and we sent it for AI analysis that looks at fluid dynamics on the CT scan to predict to see if there is actually an obstructive lesion. And you can see here a drop of a CT-FFR less than 0.8 is considered a hemodynamically significant lesion, and it correlated very nicely with the cath that we did right here. So you can see that this is very useful and a tool that we're currently using for our patients right now at But we also have a competitor that recently just came out. So now it's good to also see that artificial intelligence is taking over many things, and cardiac CTA is no exception. We can see that artificial intelligence for ischemia prediction with cardiac CTA is great. So this is a paper that was published earlier this year. And it's looking at an AI predictive model based off the plaque and the stenosis to see if there's actual true ischemia. And it's been validated on 2 large cohorts, the Credence and Pacific 1 trial. And it actually outperformed SPECT imaging, which is your nuclear stress, a portion of your nuclear stress, CT-FFRs, and just didn't do better than a PET stress. And this was actually referenced to FFR, which is done invasive angiographically with inside the lab. So I think this is an option that will be coming to a lot of our patients soon. And similar, what I think is going to start happening since we started going around through ischemia, and we've had a lot of research going into that. I think soon the next craze is going to be going into coronary plaque quantification and primary prevention. So we already know that AI can help us with ischemia prediction, but now it can actually help us with plaque quantification and plaque qualification. As you can see here, AI is actually, in this study, was actually shown to actually outperform level 3 readers in determining obstructive disease greater than 70% in these patients. And I think this, nonetheless, I really love calcium scores, and I commend everyone who's been doing them. And I see over here, since starting in the last 3 months, that a lot of patients or a lot of providers order calcium scores. But I think we definitely know that there are non-calcified plaque, as you can see here, in a lot of the patients in the top right, that's non-calcified plaque. And you can change your management by starting statin therapy very early. And a recent study actually in Miami called the Miami Heart Study was done by our colleagues over at Baptist. Actually had more than 2,000 patients get a cardiac CTA. And those who had a calcium score of 0, about 16% of those patients still had any coronary plaque, non-calcified plaque. And then at least, about 1% of them had a greater than 50% obstructive lesion, and plaque with high-risk features about 2 to 3%. And these are young patients, done in our own backyard, a predominantly Hispanic cohort. So as much as I think that a calcium score is very helpful, I think that in the future, when the guidelines start seeing a lot of this data, I think we'll be ordering cardiac CTAs for directed medical therapy for lipid management compared to just calcium scores. But at the moment, we have to do what's guidelines, coronary calcium scoring. So some take-home points. So transcatheter tricuspid interventions for high-risk symptomatic TRs coming soon. Determining between a repair or replacement will be a challenging task. Mitral annular disjunction is under-recognized and undertreated, and multimodality imaging can help us with those high-risk, determining high-risk patients. ICE is a reasonable alternative to EE for some structural procedures, and cardiac CTA will continue to advance with CT-FFR and AI ischemia-driven models, as well as plaque quantification in the future. Thank you.
Pretty amazing, Dr. Covas. No, not so fast, not so fast. So why would anyone want to go to the cath lab and get an arterial stick and get exposed to the contrast when they can just go for a CCTA and get the same and more better information perhaps and have AI interpret it for you? So why aren't we doing this preferentially over?
Well, I actually think that we're starting to do it a little bit more. So I think awareness and the possibility. I think a lot of it is limitations to getting the CT scan. So sometimes if our heart rates are not controlled, if your heart rate's too fast, you might not get a good quality scan. I think a good quality scan is diagnostic. If we don't get a good scan, then we're gonna have to unfortunately hedge on some of the reports, and you can't see the lumen very well or determine that. So if you can get a good, nice heart rate control in the 60s, we can get a fantastic scan. We have good scanners here, and that can definitely provide an alternative option, a non-invasive option for these patients.
Can it be what?
Oh.
Can the test be ordered from the ED right now?
So yes, it can be ordered from the ED. It's normally just a call to the inpatient cardiology service so that we can start facilitating that. And Dr. Hatzizis and I and the rest of the radiology team have been working on trying to get it as accessible to everyone. I think we'll have to start talking to the emergency room about chest pain rule outs and having cardiac CTA as an option. Maybe directly from the ED without having even to consult cardiology, but I think that's some time that's coming, and I think that's some of our goals that we
Wait a
plan
minute,
to go.
You mean cardiologists will become not necessary?
At least in the clinic. We'll be in clinic.
Okay. There's a question by Melissa Rodriguez. What are some treatment options for mitral annular disjunction?
So what are some treatment options for mitral annular disjunction? So what the non-invasive route would be beta blockers, calcium channel blockers in order to prevent any kind of VT. Otherwise, it is a structural disease, and the only other option is mitral valve surgery. You can do a repair. Most people end up doing a replacement, in what I've seen. And then other options that are a little less invasive, you could do, if there is fibrosis, you can do a VT ablation in order to prevent sudden cardiac death if the patient has known VT. I've talked to a lot of our EP colleagues around here, and they try to go around the ablation route first, it seems, and then afterwards ICD. And if not, and you're still having recurrent VT or syncope, then you would probably go for a mitral valve replacement.
Thank you, Dr. Covas. Thank you, Dr. Patel, for great grand rounds today. Unfortunately, this is our last one of the year. We'll adjourn until the first Wednesday in January. I wish everyone a safe and introspective and healthy holiday season. We're here if you need anything, and look forward to seeing you all back in January. Have a nice day.